Well, I want to echo Kiki in thanking the CDG Care community for welcoming me. This is a conference that I've attended regularly since its inception, and it means a lot to me to see how many people are here, because as HUD will remember, I remember being in small conference rooms in little hotels around the Midwest over the years, once in Minneapolis, once in Sioux Falls, and so to see this community grow has been just amazing for me. Kiki gave my whole talk, so I'm going to have an abbreviated version. When I planned this, she was on a different day and I was on the family day, so and then we didn't talk to each other about what we were presenting. So these are my disclosures. Part of my rare disease journey started with CDGs and has expanded to being involved in many different rare diseases and trying to help the community find therapies for these rare diseases. I work with a lot of different companies in that area. I'll be talking about off-label use of medications because almost everything we do in our kids is not approved in kids, it's approved in adults, and that's part of what we're doing. And part of what Kiki was just talking about, of finding a medicine that's approved for something else and applying it to a child who needs it, and trying to figure out how we can do that in our system with the insurance process that we have to go through. So as Kiki mentioned, abnormalities in glycosylation can have a negative impact on the endocrine axes. And I started my scientific career as a glycobiologist in the lab, learning about receptors and how they talk to the insides of the cells to make things happen. And one of the ways that we purified some of the receptors was based upon their glycosylation. So I knew very early on, when I learned about CDG, how important this glycosylation process was to the hormone system that I love and know so well. And so as Kiki mentioned, glycosylation can impact growth. It can impact blood sugar regulation, which neither she nor I will talk about today, the adrenal and puberty, which she talked about, and bone. And I did change my talk after listening to some of the talks yesterday to give a little bit more practical information about growth hormone and growth hormone therapy. As Jonathan was talking about growth hormone, I just wanted to add this in for practical information for families. So as Kiki was talking about the growth hormone and the IGF-1 axis that we need to know more about, one of the initial studies I did in CDG was trying to understand why kids with CDG don't grow. And it was sparked by my experience with a child with phosphomannose deficiency, the old CDG1B, PMI CDG, because when we gave her mannose, she grew. And so I knew that there was something different if we could get the glycosylation process to improve, that we could actually help kids grow. And so in this cartoon, you can see some of the things that Kiki was talking about in terms of the IGF-1 and acid labile subunit. So in the pituitary gland, your brain sends signals down to the pituitary to make growth hormone and help you grow. Growth hormone then goes out into the blood, stimulates the production of IGF-1 and the acid labile subunit in the liver, as well as the IGF binding protein 3. And it's that complex that takes IGF-1 out into the blood and delivers it to the local tissue or the growth plate where kids grow. And so that's how an endocrine system works. It's hormones that are developed in one part of the system that are moving to another part of the system to do their job. And so in this situation, you have to have the transport system working, the acid labile subunit and the IGF binding protein 3, or else your IGF-1 never gets to the growth plate to help you grow. And so that's a big part of when we think about CDGs and how kids may not grow, is that your liver has to be doing its job. So if there's a problem with liver dysfunction or liver inflammation or malnutrition, the liver is going to say, I'm not going to make IGF-1 no matter how much growth hormone my body makes. So even if the growth hormone system is working really well, if the liver can't make IGF-1, or if the IGF-1 can't get to where it's supposed to go, then you're not going to grow very well. And this is a cartoon that I made in like 2001. My artistic skills at the time were showing how acid label L-citrullinate has lots of little glucose or sugar trees attached to it. The IGF binding protein 3 has those sugar trees attached to it, and they actually regulate how the two get together and are able to carry IGF-1 to the target tissue. And in that initial study that I did of primarily PMM2 CDG patients, we found that the acid label L-citrullinate levels were normal, but they didn't bind the IGF BP3 very well. The BP3 levels were low, and the IGF-1 levels were low in children with CDGs. And so that causes children to not be able to respond to growth hormone that they're making, or even if we give them growth hormone. And so I think we have to think about that when we're talking about growth hormone therapy for children. So how many families in the audience have talked about growth hormone with their doctors or actually received growth hormone therapy? If I may see hands. So one there, excellent. With the lights, anybody else? I couldn't see with the lights. Okay, sounds good. Jonathan was talking about it yesterday, so I just wanted to get a sense of how much that's come up. So there are specific reasons why children might receive growth hormone therapy, some of which we'll find in CDG and some of which we won't. And so growth hormone deficiency is the main reason that growth hormone is approved for therapy for children. Typically it's associated with poor growth, low IGF-1, and failure, as Jonathan was talking about that stimulation test that he went through that was 4 hours long, where they draw your blood every 20 minutes. You have to meet all of those criteria to be able to receive growth hormone therapy in most circumstances. And in the US, we also have the opportunity to treat for idiopathic short stature, but in most of the rest of the world, that's not an approved indication. So you either have to have growth hormone deficiency or have been born small for gestational age, so smaller than you should have been for how close you were to your due date, either for your birth weight or your birth length, or both. And then you have to not catch up later. And so you have to be small when you're born and stay small. So many children with the different forms of CDG may fit that category, or if they had a normal birth weight or birth length, they may not. And so that's an important thing to think about. The primary benefits when we think about growth hormone treatment is linear growth. But I'll talk about some other benefits that growth hormone provides as well that may be beneficial. And then at the bottom, in the United States, because idiopathic short stature is an approved indication, we can sometimes get children with different conditions approved for growth hormone therapy based upon how small they are and the likelihood that they're not going to catch up without intervention. And the FDA has actually said to companies as they were trying to develop new therapies for, or new indications for growth products, that they consider any genetic condition that causes short stature in the idiopathic short stature category. The insurance companies don't agree, but that's what the FDA told different companies trying to start these therapies. So it's important, when Jonathan was talking about treating earlier might have helped him more. Any child who needs growth hormone therapy, we found that the earlier that they receive treatment, the better that they respond. And so if you think that your child is going to need treatment, it's something that we should think about earlier. Linear growth, when kids get growth hormone therapy, they do most of their catching up in the first 1 to 2 years after their treatment. So that also tells us that if we've been giving somebody growth hormone for more than a year and they're really not responding, that it might not be helping them. And since it's a shot that we have to give them, it might not be something that we want to keep doing. We know that adult height is more likely to be improved in those with growth hormone deficiency, and the children with, who are born small for gestational age, their body is naturally resistant to growth hormone, and so they may not respond as well as somebody with growth hormone deficiency, and similarly in idiopathic short stature. But there are non-growth benefits, and so I talk a lot to families about the hypotonia. And growth hormone can improve your muscle mass. It can't improve how the muscles work. So if there's an intrinsic problem in what the muscles are doing or the message that they're receiving from the brain or the lack of a message from the brain, giving them more muscle isn't going to make a difference. But also, when we see those muscle benefits, it's usually in the earlier years. And so when I treat children with Prader-Willi syndrome, which is a condition with severe hypotonia, they get their biggest benefit in those first couple of years because they get more muscle to help them do the things that they're trying to do. We think, as I'll talk in a moment, that that also improves their bone density because having stronger muscles actually helps your bones get stronger as you get older. Growth hormone we think of as something that helps people grow, but it's actually more of a nutritional regulator. It's how your body decides whether to make muscle and bone or to store calories as fat. And so if your body has an imbalance between inadequate growth hormone, you're going to tend to add that nutrition as fat rather than add that nutrition as muscle and bone. And so a growth hormone deficiency, if you're deficient, you're not making the muscle and bone as well as you should, and growth hormone can encourage you to do that. So how do we give growth hormone therapy? It's a daily shot. It goes under the skin, so it's not an in-the-muscle shot. And treatment, once you start it, you actually need to continue it until kids are almost done growing. And so it's a long-term investment in how kids are growing. So it's a big deal if you think your child really needs it. It's a long process. We've had daily recombinant growth hormone since 1985, and we have many years of exposure data showing that it's safe and effective. But now, in the last 5 years, we actually have a weekly version of that medicine. It's only approved in kids with growth hormone deficiency for the majority of the products. And then there's one that was just approved in February for children who were born small for gestational age or who have idiopathic short stature. And the early data from those long-acting growth hormone therapy shows that it's been as safe and as effective as daily growth hormone, but it's a short window of time. So I just wanted to provide that kind of background after the conversation related to growth hormone treatment. Kiki's already talked a lot about puberty, so I'm going to skip over that to some degree. This is the curves that she was talking about how the hormones are very active before babies are born. Then there's a little bit of a mini puberty right after they're born in this 2 to 6 month age range. Then the puberty hormones are shut down, and then they fire up again, and that's what the kind of puberty that we normally think of. And most families are very anxious about what's going to happen during puberty and how do I avoid it if at all possible. But since it's going to happen, or we might have good reasons to make it happen, how do we navigate that equation? And so, Kiki talked about the timing of puberty. These are the timings of typical pubertal development, and you can see the breast buds, the growth spurt, the cycle, and in boys, the enlargement of the testicles, the growth spurt, the change in voice, all the things that we typically think of happening during puberty. And she also mentioned the regulation of the menstrual cycle is a very coordinated process that the body has to make these hormones in a consistent pattern to make happen. And those patterns are affected by glycosylation. And she mentioned two main hormones, LH and FSH, and this is a cartoon just showing the different N-glycoproteins that are involved in that process. And they're very important not only in keeping the hormones around in the blood for how long they're supposed to be, but also in how those hormones interact with their receptors. And so that's part of why we see differences in CDG, and as she mentioned also, it's the receptors of that are listening to these hormones and how they work. It's the downstream proteins that they're stimulating. It's the carrier proteins in the blood that are carrying around the hormones. So all of these pieces are impacting how that happens. And actually in postmenopausal women, the way the sugars look on FSH is different in typical women, and unfortunately girls with CDG have a glycosylation pattern that looks more like a menopausal woman than it does like a woman who's actively menstruating and fertile. So what is the spectrum of puberty I'll start with CDG girls. So first of all, we do have some case reports of girls having early puberty with early menstrual periods. We've had a number of reports where girls have had very typical and normal pubertal development. We had a patient that we published who had pubertal development that was normal timing, and she was hypervirilized. Many have delayed puberty, and then the majority have, in PMM2 in particular, as Kiki mentioned, have hypergonadotropic hypogonadism, which is basically the ovarian failure model, where the LH and FSH are screaming at the ovaries to work and make the hormones, and the ovary is not able to listen. And we even have a report of a patient with PMI CDG with pregnancy. So what are the treatments that we think about for puberty? Treatment of pubertal symptoms, prevention of pubertal symptoms, and I mentioned yesterday in one of the family meetings that one of my biggest partners in this process sometimes is the gynecologist, to help say, what do we do to manage the menstrual cycles in girls, whether we're giving estrogen or whether they are making their own estrogen. And that's an important conversation for families to be having with their medical team, and maybe the 12th specialist that you get to add to your list of folks. We talked a little bit about estrogen replacement. I'm just going to give a little bit of information there in terms of we tend to want 17-beta estradiol. As Kiki mentioned, if you give it orally, it has an increased risk of causing problems with the blood clotting system. So we prefer to use them as patches to give the medicine across the skin so it doesn't go to the liver first. Your body listens to that better. We want to try and mimic puberty development, and so she talked a little bit about increasing the doses over time to try and match what naturally happens in women over time. Adding in a progesterone later to actually allow the cycle to happen, and when we might do that, or we may be giving it continuously to avoid the cycle entirely, because most women never want to have a period if they can avoid it. So there are some questions about which progesterone, whether we give it 10 days each month, 5 days each month, or continuously. So those are also important conversations to be having with your medical team. We want to be monitoring what's happening. We can actually monitor that clinically by what's physically changing, but also by levels in the blood. And then if we're having abnormal bleeding, there are ways that we can investigate to help regulate that. Kiki already talked about the thrombosis risk, and Eric Eklund had been asking me for about 10 or 15 years, what do we do for girls when they're on estrogen with the stroke-like episodes and the seizures? And so Eric, Alex Boucher from our center, and I wrote this article about some of Eric's patients and how they had used some of the anticoagulant medications to reduce the likelihood of those thrombotic events. And as Kiki said, now we want to ask, what are people doing around the world? What would they do in those circumstances? And collect that information, because as somebody asked me yesterday, in 10 years, I want to be able to tell families, we now have data to say that this is a good practice, that we need the estrogen for our girls' bones. We need them to have these hormones in their system, but we also need to know that it's safe to do and what's the safest way to do that for our patients. And so that's our goal. So we promote the idea that girls receiving HRT should receive prophylactic coagulation, but we recognize that the evidence for that is currently anecdotal, which means we need more data. I just said that. So for boys, we have the spectrum of undescended testicles. We have small penises in 2 boys, normal pubertal development, delayed puberty, and then hypogonadism or low or normal testosterone levels. And we were talking at the poster over in the poster room yesterday about how we really need more data, because some of the data that we have, and Kiki mentioned, is snapshot data, single evaluations rather than longitudinal evaluations. And we need more of that longitudinal data to say, in boys, is puberty normal or is it affected? And is it different in different CDG forms? So in general, we think that boys have smaller testicles and lower testosterone levels than the general population. So if we had that growth chart for PMM2 CDG for their testosterone levels, we would likely see that it's not going up like we would expect it to in typical pubertal development. So when we're thinking about testosterone replacement, and Kiki talked about this as well, we're doing a very similar process of giving low doses and increasing over time to try and mimic normal puberty. I put this up because around the world there are lots of different options that people will use to jumpstart puberty. In general, we use the injections to try and increase slowly through puberty, primarily because with the gels and the pills, we don't have a lower dose that we can adjust very well. So with the injections, we can adjust it and ramp it up in lower doses that make sense for the kids. There are also some patches, some nasals, some pellets, some buccal administrations that are approved in adults that we might be thinking of for our adult patients with CDG in the future. So lastly, I'm going to talk about bone, and Kiki already did an excellent job of talking about this. So how many of you have been told that your child has osteopenia? Yeah, pretty common. And the reason that happens is because they'll do an x-ray and they'll say, those bones look washed out. They look paler than other kids' bones. But unfortunately, osteopenia is more of a quantitative thing, and x-rays don't do a good job of it. And so that's why DEXA scans, as Kiki was talking about, DEXA is dual energy x-rays. It's 2 x-ray beams that are saying, what's the density of different tissues? I can tell how much bone I have, how much muscle I have, how much fat I have when I do a DEXA scan. Osteoporosis in kids, in adults, we actually define it by a DEXA scan showing low bone density, but in kids, we only define low osteoporosis if kids are fracturing. And so that's different because they have to have a fracture with low bone density as the cause of it. And so, as Kiki mentioned, nutritional, hormonal, and physical reasons, that low muscle tone that's not stimulating the bone growth is important. The immobility or reduced weight-bearing activity is also important. The many factors, nutrition, vitamin D, calcium, the hormones, environmental factors like exercise, medication, and illness, and then our own underlying genetics, not the CDG, but our background genetics also impact how our bone density develops. So we recommend DEXA scans. 5 years and up is when we have the best data for DEXA scans to know what's typical for kids. There are more recent data that go down to younger children, but that data isn't available everywhere that you're getting a DEXA, including my hospital. We don't have reference data for the younger kids on our machine, and our machine's sold. We can't upgrade it, so can't do that. So as I mentioned, to diagnose osteoporosis in kids, we actually have to have a clinically significant fracture with either one long bone fracture of the lower extremities or a vertebral compression fracture, or 2 or more long bone fractures of the upper extremities along with low bone density to diagnose it. So the treatment of osteopenia, osteoporosis, or poor bone health in children is to weight bear as much as we can to make sure we're getting the calcium and vitamin D and trying to offset the medications that we may be on, like acid blockers or anticonvulsants. We know that this process is affected by glycosylation and by lack of sex steroids. So those are all things that we think about. If osteoporosis is present, and I didn't include the important caveat that some kids may not be eligible for bisphosphonates, but there are also other therapies. And one therapy that we haven't talked about in the past for kids with their bones is parathyroid hormone. In the past, there was a black box warning saying we couldn't use PTH in kids, but it's one of the few things that we have that can actually help bone grow. And so we tend to now use it in children who are having fractures, particularly if they're having problems with spine rods for their scoliosis, that the rods are going in and they're actually coming back out. So there are certain circumstances where we'll use that new medication that's been around for a while, but newly available in kids. So to summarize, the endocrine system is affected by glycosylation through its impact on how the hormones signal, how they get to their target tissue, and how they do their job. We can see that the different CDG forms are affected differently, and it can also be different at different times of life. Screening for the endocrine complications of CDG is necessary to allow for treatment, and treatment of the endocrine complications often requires hormone replacement or other therapy that's targeting those specific complications. And so I think as I've been at this meeting year after year after year, I've learned from you the pieces we need to do to help you, and one of them is to help guide what should your doctor be doing for the tests to screen for endocrine problems early. How do we help them say, when should you see an endocrinologist and when don't you need us on your list of specialists? And then how do we help say that the therapies that we're recommending for your children are safe? And so those are the pieces that I come away from each of these meetings with sort of reinvigorated as a member of the community to say, how can we help your kids' lives better? So thank you for letting me be here.